Welcome to our webinar, another webinar about intermittent claudication, physiotherapy for intermittent claudication. Peripheral artery disease affects millions of people in Europe. Many of them will suffer from intermittent claudication, which is our topic tonight. And although we have a lot of strong evidence for the effectiveness of physiotherapy and recommendations for implementation, this is generally not done. One country where physiotherapy for intermittent claudication is offered is the Netherlands. To offer evidence-based practice, the KNGF, the Dutch association, has produced a guideline which is regularly updated, and tonight we will hear about the guideline and the latest updates. Following the presentation by Thomas, our panelists will add from their own expertise about different aspects of the topic. And then we will have a discussion. And during the webinar, you can comment and post questions in the chat or Q&A. And Leah, who is with us as well, will manage the chat and bring your questions to the discussion during the webinar or at the end of it when we have the discussion. And so first, we will let our panelists introduce themselves. I'm sure they'll do it best. So Leah, you are the co-host, so if you can say a few words about yourself.
Good evening, my name is Leah and I am a physiotherapist living and working in Cyprus. And I'm helping tonight.
First of all, thank you for having me and letting me talk about this interesting topic on how we in the Netherlands developed I think a best practice example of value-based and evidence-based physiotherapy network care. I really think the example that I'll give you today could be a great blueprint for other countries as well. So I'm very happy that you're not sitting on the couch watching Squid Game season 2, but decided to spend your time with us. So I'd like to kick it off immediately with who am I? I'm a trained physiotherapist, not practicing at anymore. Also trained human movement scientist. And I currently work as an associate professor and research group leader at the Radboud University Medical Center in the Netherlands. So I'm Thomas from the Netherlands. And here you can see me with my son, who's a big inspiration for me, and you'll see more of him during the presentation as well. I have a number of disclaimers. I have limited to no experience with this particular patient population. I'm really working as a researcher, so please don't hold that against me. I collaborate with KNGF, the Royal Dutch Federation for Physiotherapy, and Chronic CareNet. And I'll talk a lot about them. They don't pay me, unfortunately, but I'm gonna promote them a little bit for the great work that they've done on this topic. And yeah, as I said, most of my presentation will be about the successes of other people. And finally, at the end, I'll talk briefly about some of the innovations that I was involved in as well. Today, I'll explain how care for people with intermittent claudication was and is organized in the Netherlands. I'll provide insight into the specific role of Dutch physiotherapists and their professional bodies in realizing this new type of network care. I'll reflect on the role of guidelines, with what role did they play, and the collaboration that we have with medical specialists. And finally, I'm hoping to showcase some further possibilities when you've set up such an evidence-based physiotherapy network, what other things you can do, which is, I think, pretty cool. Because this slide is so boring, I decided to hang an upside-down plant next to it to compensate for that. What is peripheral artery disease and what is claudication, intermittent claudication? So peripheral artery disease is a narrowing of blood vessels supplying mostly the legs due to atherosclerosis. The prevalence is, well, there's a lot of different numbers on that. I found that around 10 to 15% of the population over 50 has some form of peripheral artery disease, which would account for over 200 million people worldwide. Risk factors include smoking, diabetes, physical inactivity, obesity, dyslipidemia, and finally, what is intermittent claudication? That's the most common symptom of peripheral artery disease. Later on in the presentation, I also talk about symptomatic peripheral artery disease, which is similar to intermittent claudication, which is typically expressed as pain and cramps in the legs during physical activity. So I want to go back 20 years ago, what we were doing in the Netherlands. And I found out that around this time, 20 years ago, we were very concerned with the domino D-Day sparrow. The domino D-Day sparrow was a sparrow that flew into a building where Dutch people were playing with dominoes. We were trying to set a world record. This is what kept us going 20 years ago. This was what was important in our lives, Domino D-Day. It makes you think what happened in the last 20 years, but that's a discussion for another time. This bird flew in 20 years ago, taking out 23,000 domino stones, which shocked the whole Netherlands. And they decided, and this, when I read this and I went back like 20 years ago, oh yeah, we had that domino D-Day sparrow. It kind of felt like a quick fix. We could have probably done that a little bit differently. Here you can see the actual sparrow. After it got shot, it ended up in a museum, caused a whole uproar. But it felt like a quick fix. And the quick fix also reminded me of how we used to treat people with symptomatic peripheral artery disease. After all, 20 years ago, almost everybody got an angioplasty or stenting, while supervised exercise therapy was hardly ever described. So clearly, going for an operation or surgery is considered a quick fix. Working on yourself, being part of an exercise regime, that's more difficult. And the evidence for exercise therapy in this specific patient group was already emerging. But for a lot of our medical specialists in the Netherlands, it was unclear which physiotherapists were actually specialized in treating this patient group. So that also hampered the further implementation of supervised exercise therapy. But, and this, as you can see, is a big but. In 2011, KNGF was founded by a medical specialist called Rotem. He's a vascular surgeon. And to be honest, when the network was set up, and we have multiple networks in the Netherlands, for example, also in Parkinson's disease, led by a neurologist, I felt as if they were mingling in our field, that they were making decisions for us, but we were autonomous professionals. They shouldn't be telling us what to do. And only a couple of years later, I started realizing, no, I've been at it completely wrong. I felt like I had to defend, oh, this is my profession, don't come into my area, this is what I do. But you actually need to work together. You need to collaborate in order to make real progress. So rather than fearing our medical specialists, we should start to embrace them. That's my philosophy. And then they started implementing a stepped care model for people with peripheral artery disease. So what they did was they implemented the model where the vascular surgeon or the general practitioner would set the diagnosis. Then they would initially refer to cardiovascular risk management and lifestyle advice. And if that didn't help people enough, people would be referred to a physiotherapist or an exercise therapist in the Netherlands. And they would get supervised exercise therapy, including lifestyle counseling, medication compliance, and some other things as well. This was recommended to last for 3 to 6 months, and then they would get a re-evaluation, and people would either continue supervised exercise therapy or stop if they recovered enough. If there wasn't enough progress, other decisions could be made, like percutaneous treatment or surgical treatment. So this is very simply the model of the step care model that was implemented in the Netherlands. A recent study or a PhD thesis of Marijn van den Houten showed that starting with supervised exercise therapy actually saves around 6,500 euros per patient. It can reduce revascularization rate, improve 5-year survival without harming the quality of life of the patient itself. So you can do the math for yourself and determine like how many people are there approximately in my country with peripheral artery disease and intermittent claudication symptoms. And you can do a quick estimation of the direct cost. So in the Netherlands, it's estimated that implementing physiotherapy care through supervised exercise therapy saves on an annual basis around 25 million euros, which is a lot of money, as well as a great way of improving the care for this patient group. So what they also did at Chronic CareNet is they developed a tool that allowed medical specialists to find specially trained physiotherapists. So in the Netherlands, there are approximately 2,200 physiotherapists trained, a part of this network, which means that if you are part of this network, you follow the training to understand what the guideline says. You are willing to collect clinical data. You have the right attitude and you want to contribute to the network itself. You follow the course in motivational interviewing, and you are part of a lifelong learning culture. People who are part of the network also pay a form of contribution on an annual basis. But what they get in return are these referrals from medical specialists to their practice. And several health insurance companies have made specific agreements with Chronic CareNet, Chronic CareNet, that people are reimbursed more money when they're part of the network than when they are not. So, 2011, Chronic CareNet was founded, and in 2012, different international and national guidelines also started recommending supervised exercise therapy as a primary intervention for people with symptomatic peripheral artery disease. I'm going to run through a couple of these guidelines real quick. This is the guideline from the general practitioners in the Netherlands, and they say refer for supervised walking training or exercise training to a physiotherapist in case of intermittent claudication. This is the first recommendation they do. All the other recommendations are if this therapy would fail. The Federation for Medical Specialists also have a guideline on peripheral artery disease. They say always start with supervised walking training under the guidance of a physiotherapist for patients with intermittent claudication. But this is not only in the Netherlands that guidelines are recommending this. Also in the NICE guideline, for example, they state offer a supervised exercise program to all people with intermittent claudication. So it's clear what we need to do. The GPs tell us, the medical specialists tell us, and that meant that the Royal Dutch Federation for Physiotherapy also had to come up with a guideline for the management of people with peripheral artery disease, and they did. It's on the website. You can scan this link. I think the presentation will be uploaded on YouTube, so don't worry. You can scan. Also, if you're too late, you can go back to the YouTube channel. And what they did in this guideline is they made recommendations regarding the diagnostic process, the therapeutic process, and we did an update to get more information in the guideline regarding shared decision making. I want to go through these different guideline recommendations. It's important to realize that I translated them from Dutch, and sometimes I shortened them to fit the screen a little bit better. So if you want to look at it yourself, I would recommend to just go to the website and translate it using some sort of a large language model. Okay, for the diagnostic process, there are a couple of recommendations. Use treadmill tests with increasing load to determine functional and maximum walking distances as an indication of the severity of complaints. This has also become part of what people in the network of Chronic CareNet or CareNet do, is they are trained that before they start, they obtain a treadmill test after 3 months, after 6 months, after 9 months, after 12 months, to monitor the progression over time. And it's important that you use one with an increased loading as well. But there's more information on that in the guideline itself. There's also a recommendation to use the American College of Sports Medicine pain scale to score pain during walking. And there is a very limited recommendation that for people where there is a change in gait pattern, which would hinder the patient's walking ability, you can consider evaluating the patient's gait as well. But especially there's stronger evidence for the first one, use the treadmill tests to monitor your treatment. So then they go on to the therapeutic process. They first talk about the content of the intervention. It's strongly recommended to use exercise therapy to increase walking distance. And it's important to realize that this exercise therapy can include alternating walking and resting, active leg exercises, physical training or treadmill training, potentially combined with muscle strengthening. And you can use, more specifically, walking exercise to increase functional walking distance. Walking exercise is preferred. If walking is too burdensome for the patient, other forms of exercise, such as cycling, can be an alternative, particularly at the start of the treatment. So these recommendations date from 2014. We did an update, which is part of the shared decision-making process, and you'll see that there's a little more nuance on these two recommendations there. They then talk about the dosing of your intervention. The working group advises to train these patients for at least 6 months. There's no specific recommendation that can be made regarding the training intensity. Both low and high intensity exercise programs seem to lead to increased walking distance. Exercise frequency, the working group advises to train 3 times a week, and the duration at least 30 minutes per session. Again, there are some changes later on that I'll get back to. There's also some other considerations. Supervision. Supervised exercise therapy is strongly preferred. No recommendations can yet be made regarding the optimal number of supervised sessions. Improvement of gait pattern. No recommendation can be made regarding the use of exercise therapy to improve the gait pattern. And the impact of comorbidity. And I think we'll get on or have a discussion on this topic later on as well. Physiotherapists should design the program while taking comorbidities into account. If the comorbidities significantly impair the effectiveness of physical therapy, consultation with the referring physician is recommended. Okay, so these were all the recommendations that were part of the first guideline for people with peripheral artery disease. And last year, we made an update where we found that the guideline in some way appeared to be a little bit too strict, and people would use the same type of intervention each time. So they would always prefer walking exercise over other types of trainings. They would always start with 3 times in the week training, 30 minutes, and they had a similar building off schedule. And we thought, well, maybe we should look into what parts of this treatment program patients should also have a voice in. And that's where the update came from. And we ended up recommending that the physiotherapist should use shared decision-making to choose the form of movement intervention. So it shouldn't be always walking exercise, which of course makes sense to choose and to pick. But there's also evidence suggesting that other types of movement interventions do not result in less benefits for this patient group. So if it's preferred by the patient to do it in another way, you could consider doing that, but you have to have a good conversation about that. You can use shared decision-making to determine the intensity of pain during walking exercise. At the start, people thought you need to suffer through these interventions. You need to at least have incredible pain for the therapy to work. But there's no real evidence for that. And exercising without pain can also result in similar gains as exercising with pain. But some people really want to push through the pain. So again, this is a topic for discussion. And you can also talk about what fits a person best. Is that aerobic exercise or strength training, or a combination of that, a combination of the two? Again, you need to discuss this with the patient. There's also a recommendation that I didn't include here because it referred the reader to a whole different guideline. But this said that also supervision of the exercise therapy should be discussed with the patient. And if the patient believes that they can do it unsupervised, and you think that could also work, and you come to a shared decision on that, there's another guideline in the Netherlands that can help you how to properly monitor people unsupervised in their therapy. This was probably why I was invited. They asked me, tell us about the update of the guideline. So I did that. I also want to go one step further. Because in 2016, CareNet reached nationwide coverage. And in 2017, 87% of all people with symptomatic peripheral artery disease in the Netherlands received supervised exercise training as a primary intervention. This number has only increased since then. So that's a really good sign. But as I showed, there are therapists, trained specialized therapists throughout the Netherlands at this moment who are part of this network. And if you have such an evidence-based physiotherapy network, you can do a lot of fun things. So all these therapists also collect data, which means that they can show that can be transparent about their outcomes. You can have different discussions with your healthcare insurers and maybe come to a better reimbursement scheme. You can set up a learning healthcare system. You can do scientific research, and you can build prognostic models. So the way it looks like that now in the Netherlands, you start out with the CareNet therapist. They collect their data through a set of health indicators, and they collect that in their electronic healthcare records. These electronic healthcare records collect data across all electronic healthcare records into the National Registry for Physiotherapy. You get uniform data gathered through standardized measures and questionnaires by therapists. And those data are then again shared with CareNet, and they can use that data to improve care, stimulate continuous learning with the therapists, and also at the level of the practice and at the level of the network. And this is where I came in. I knew this network was set up in the Netherlands. I thought, wow, these data are amazing. And I just had my baby boy born, and I was really enthusiastic about going to the consultation office with my son, because they would measure him, and he was very small when he was born, and they would plot how he grew over time. But I always thought, well, I didn't just bring in a boy. I brought in the best boy in the world. They should at least correct for that, correct for how awesome my child is. And then we have a completely different idea of how his growth was. Because here it was suggested first that he was too small, and later on that he was too fat. But I thought, well, probably this is the way my boy grows. So if we had more babies like my baby, and we could compare how those babies would go over time, we get a much better prediction. And this formed the basis for person-centered evidence-based practice, where we started out with looking at all the data of people in the database of the National Registry for Physiotherapy. And you get a graph, something looking like that, where the walking distances of all patients are in the graph. This isn't that useful. But let's say someone comes into your practice, let's call him Bob. And Bob, he's a male, he's 65 years old, he has a BMI of 28, he's still smoking, a very low walking distance, his motivation is pretty good, his quality of life is pretty poor. We could look into the database that we have and select people who look like Bob, and project what these people would did over time. So only present the people that look like Bob. And then you get something like this. And this is a screen shot of the quality framework of Chronic CareNet. And here you can see all the different Bobs that are in the database. And you can see that the prediction is actually more precise than when you plot all people, also the not Bobs. Again, a great thing about this plot, you can also remove the individual lines, but you can have a different conversation with people. You can talk about, like, what do you think? Oh, sorry. What do you think that this person did? Well, Bob probably tells you he probably stopped smoking. He did his exercise really well. We don't know. But you can, through motivational interviewing, get a whole different conversation. And it can help you monitor over time how Bob is doing. You can discuss whether he is happy with the way he's doing or whether he's lagging behind, and you can have a discussion on how to change the therapy. I think monitoring the outcomes over time should be our main priority. I think that sets us apart as physiotherapists from other healthcare professionals. We have the time to monitor and to evaluate the quality of our intervention. And then we went even a step further. This is the work of Laura Marcellus, who's here also tonight. I saw her name in the chat. She developed a tool to elicit shared decision-making. So when you're looking at the graphs with Bob, after that, you can build your treatment plan together with Bob and have his input on how he would like to train. So the whole shared decision-making process is now part of the working structure of physiotherapists in CareNet. I think I won't go into much detail here. This is a whole presentation in itself. I want to get to the end of my presentation. I also see Nirit move her hands very heavily, so I got the hint. I think we need to move physiotherapy forward. We need to be involved and work together with our medical specialists. We need to build special care networks and have just really good, unified and uniform care. So rather than shoot our little sweet sparrow and go for the quick fix, I think we need to build these data ecosystems where we work together in a team as a learning healthcare network. So we need to stop shooting the sparrows and start loving them. That's my message for today. Thank you all for your attention. I put in some QR codes to the guideline here for the peripheral artery disease. For more information on the Chronic CareNet or CareNet, and if you want to follow me, you can do that as well on LinkedIn.
Hello, everyone. Thank you for the invitation. My name is Manos Stefanakis. I am from Cyprus. I work in the University of Nicosia. And my background is spinal physiotherapy, musculoskeletal physiotherapy, and sports physiotherapy. And I hope I can add a few things about neurogenic claudication. We will hear a lot about vascular, but neurogenic claudication is something that troubles a lot of people. So maybe we can add a couple of comments about that. It is really important to use exercise for neurogenic claudication as well and trying to improve patients' life. And definitely the way you did it, creating a network, collecting data, big data, and supporting the work you do with data. This is really something we need to look at for neurogenic claudication as well. There is a postural component. We can go into details if there are questions about it, but for me, it is an amazing job that you did there, and it's very inspirational, and congratulations to you and everyone in Netherlands.
Good evening, everyone. My name is Robert Vysoký. I'm from Czech Republic. I am a cardiac rehabilitation physiotherapist in Faculty Hospital in Brno, St. Anne's Hospital. And at university, I am associated professor and guarantee of physiotherapy study program. My expertise for this seminar focuses on the similarities between different cardiovascular diseases. My presentation or my speech is about to compare similarities between different cardiovascular diseases. I've chosen ischemic heart disease and post-heart attack rehabilitation as these are the most common conditions we work with in cardiovascular rehabilitation. Shortly, in the Czech Republic, we started structured rehabilitation with cardiac people in 1993. The first hospitals to implement international rehabilitation methods were University Hospital in Brno, and first guidelines in cardiac rehabilitation were introduced in 1998 and published as a recommendation for cardiac rehabilitation under Czech Society of Cardiology. What about how rehabilitation works? Before training with cardiac rehabilitation patients, we need to confirm their diagnosis and review their medical plan, understand their risk factors and physical condition, and we have hospital-based rehabilitation and outpatient. Shortly about hospital phase, after uncomplicated heart attack, rehabilitation starts in the hospital and lasts 3 to 5 days. The focus on is on helping the heart adjust to daily activities, monitoring blood pressure and heart rate during movement, and education patients. Patients are then encouraged to join the next phase of rehabilitation after discharge. It's outpatient. It starts 3 to 4 weeks after discharge and lasts 2 to 3 months with 2 to 3 training sessions per week. Before training, exercise testing, optimal cardiopulmonary exercise test, and we are setting optimal training intensity. The training program includes a mix of cycling, treadmill, walking, and rowing exercise is specialty in our hospital, with continuous monitoring of heart rate and blood pressure. Now we are focused on telemedicine rehabilitation. If we have low-risk patients, rehabilitation is either fully supervised or done using telemedicine. So in telemedicine programs, we have 6 sessions first, supervised, and after our patients continue training while being monitored remotely using smartwatches and online platforms. But patients with heart failure, those waiting for a heart transplant, or those with complex health issues always require fully supervised rehabilitation, so they are supervised. I would like to react on a slide Find Your Therapist. It was very interesting because in our country we have no list of specialized cardiovascular physiotherapists, because in our country is only 3 or 4 major hospitals specialized in this area. So in our country, it's about 15 to 20 physiotherapists specialized in exercise training in cardiac people, so it's not so much specialist in physiotherapy. And what about our future directions? Expanding telemedicine in rehabilitation, to make programs more accessible for our people or our patients, and studying rehabilitation, exercise before major surgery in patients with heart, lung, or cancer-related conditions. So it's our main topics in, I think, in Middle Europe, or I think in all around the world, in to have a better compliance with these patients. So that's everything for me. And if you have some questions, I'm open to tell something about your questions.
Good evening. My name is Michal. I'm a physiotherapist. I'm a lecturer in the physiotherapy department at Ariel University and also a clinician at the Endocrinology Institute at Sheba Medical Center, which is the hospital in Tel Aviv and Ramat Gan. Thank you. I would like to add some more points, as you said, in comorbidity. So when it comes to PAD, comorbidities are very common and can significantly influence both the progression of PAD and the overall health outcomes in our patients. So there are several conditions often co-occur with the PAD, and these comorbidities can worsen the outcomes of PAD or even increase the risk of complications. Some of the most common comorbidities include, as Thomas said already in the presentation, first of all, cardiovascular disease. Individuals with PAD are at a higher risk of heart disease, including coronary artery disease, heart attack, and heart failure, of course. The underlying cause of both PAD and cardiovascular disease is the atherosclerosis, meaning that if a person has one, they are more likely to have the other. The presence of both conditions, PAD and cardiovascular disease, increase the risk of major cardiovascular events like heart attack and even stroke. Second, comorbidities, which is very, very common, especially in our country, is the diabetes. And diabetes, particularly the type 2 diabetes, is a significant risk factor for developing PAD. Increased glucose levels can lead to damage of the blood vessels, increasing the likelihood of the atherosclerosis and narrowing of the arteries. Diabetic patients with PAD are more likely to experience severe complications, including ulcerations, infections, and poor wound healing in the lower limb. Also, hypertension, high blood pressure accelerates the process of the atherosclerosis, which can contribute to the development and the progression of the PAD. Hypertension is a modifiable risk factor, which can be altered in doing physical activity, of course. There is also strong link between PAD and the kidney disease. Both conditions share common risk factors such as diabetes, hypertension, and the atherosclerosis. And additionally, kidney disease can worsen the prognosis of the PAD by contributing to fluid retention, increased blood pressure, and poor circulation. Smoking, of course. Smoking is one of the primary risk factors for PAD, and it can also contribute to the development of other comorbidities such as chronic obstructive pulmonary disease, the COPD, and lung cancer. Smoking accelerates the buildup of the plaque in the arteries, exacerbating the PAD symptoms, of course. Obesity is also, like being overweight or obese, is another significant risk factor for both PAD and other comorbidities such as type 2 diabetes, hypertension, as hyperlipidemia, as I mentioned before. So when a patient has multiple conditions, it can be difficult to discern which condition is causing certain symptoms such as leg pain or fatigue. This might delay the diagnosis and appropriate treatment. Managing PAD effectively requires addressing all comorbidities conditions, not just the PAD itself. Treatment strategies may include, as Thomas mentioned before, the lifestyle changing, some medications, and of course, the multidisciplinary approach, since PAD often coexists with several other conditions. A team of healthcare providers should collaborate to provide the comprehensive care.
Would you say that treatment, you would do a behavioral, a physical activity treatment for neurogenic inflammation, neurogenic claudication?
Yes, we need the exercise, and we need the lifestyle and behavioral stuff as well. So we need to utilize treadmill-based exercise, bicycle exercise, strength training, but we need to use cognitive behavioral technique, motivational and interviewing to increase the compliance of the patients with our program, with our exercise program. And also we need to supplement that with lifestyle physiotherapy. So we need to look at the risk factors. We need to look at lifestyle modifications into, for example, the postural component, how they sleep, how they sit. I'm talking about the neurogenic now. And that's why I think this talk and what Thomas presented is a very good idea for treating neurogenic claudication as well.
We have two questions. Already Thomas had answered, but if anybody else wants to comment specifically, the first one is there a connection with high levels of lipoprotein A? And Thomas answered that he's not an expert, he said, but given that this is a risk factor for atherosclerosis, I would think yes.
Michal, do you know if there is a connection?
I believe so, but I'm not sure, especially with the lipoprotein A, no. But I know that hyperlipidemia is surely a real risk factor.
And there was another question here?
Yes, there was another one regarding the specific protocol. A specific protocol on intermittent walking or walking in different angles and speeds. And also Thomas answered and said, yes, typically therapists use the Gardner protocol for the treadmill testing. For the walking exercise itself, different angles are not really discussed. The walking speed should be discussed together with the patient using shared decision-making.
And thanks. And regarding shared decision-making, there is some talks about whether aerobic exercises are best or strength exercises are best. And I liked that you said, Thomas, that I mean, let the patient do what they like to do. So for you and for the panelists, do you think there is a meaningful difference if you do aerobic exercises for intermittent claudication and for other NCDs, or strength? Is there is the difference between the two meaningful? Thomas, please.
Well, we looked at this and we decided that the difference wasn't meaningful enough to recommend one over the other. Therefore we said, well, you should have a discussion about this. However, considering that especially walking and functional walking is really important in the lives of patients, when you go out of the house and you walk to your grocery store, that's really meaningful. So I think many of the people, the therapists in the Netherlands will choose or recommend aerobic capacity also to train more in a functional way. But no, there's not really a clear difference between the two. And there was another thing that I wanted to address. Oh, yeah. Just now someone said, I'm not sure who it was, but if the patient wants to do this, then we should do that. That's not shared decision-making. Shared decision-making, we have to remember we're still physical therapists. We are the thought leaders in that process. But we have to inform people about the different options that there are, about their the pros and the cons about them, the evidence that's available. And we can also have an opinion. And I think shared decision-making is a process of finding the common ground where you can work together and build your treatment plan from. If we just started listening to patients and tell us what needs to be done, we get something like demand-based practice, which I don't think is a very good way of practicing.
Thanks. So I wonder, because we've got from different countries here, Manos and Robert and Michal and Esther-Mary, you can join in. And even do physiotherapists treat people with intermittent claudication in your countries? Manos?
Yes, definitely. We treat people with neurogenic claudication a lot. I treat a lot of them. And my cardio colleagues treat people with vascular claudication. I just like to make a quick comment on the previous question. I think is extremely important to inform the patients about the risk, the benefits, the difficulties, the ways to implement the exercise, and have an honest discussion, including, presenting our opinion to them. For example, for neurogenic claudication, and I imagine for vascular claudication as well, the main problem is they get cramping pain when they walk, and that reduces their participation in their social roles. So suggesting a treadmill-based exercise for me is very important. So I would emphasize this in my treatment. Now, if the patient doesn't, for some reason, want to comply with that, then the most important thing is to achieve some sort of compliance with exercise, because we know exercise can be beneficial, extremely beneficial. So if the patient, for some reason, has a problem with my suggestion and with my arguments, then I would go with his preferences, because I think exercise is extremely helpful. It has other collateral benefits. So I prefer to take advantage of the other collateral benefits and have the patient exercising than not having to do what I suggest. This is just to reply to comment by Thomas. No, we don't do like physiotherapy preferences of the patient. We have our own opinion, but for me, it's extremely important to get people back to physical activity and exercise and everything. So that's why I might compromise with some of his preferences sometimes.
Thanks. So, Robert, do you have in your country, do physiotherapists treat intermittent claudication?
In my country, in Czech Republic, we don't have special rehabilitation programs focused on peripheral artery disease, but it's in this treatment is as a part of cardiac rehabilitation by patient with coronary artery disease or another internal diagnosis. So it's focused specifically in SPA or or in spa facilities, it's typical for Middle Europe, this spa and balneology facilities, but we don't have specific rehabilitation programs, and we would like to focus on it. It's, I think it's very interesting to be in this seminar and implement this treatment in our rehabilitation programs in Czech Republic.
Thanks.
But do you follow the international guidelines, Robert?
Yes.
So that's important because we don't have in Cyprus, but we follow the international guidelines, I think, most of the time.
Yes, 2 hours ago, I discussed it with our president of Physiotherapy Union, Vladan Toufar, and we will implement it in our country. We discussed about it 2 hours ago, this before this seminar.
Thanks. So I actually think that one that's important that you're saying that, because when we started doing the webinars a while ago, it was part of it was a commitment to advance lesser known or lesser talked about parts of physiotherapy practice. And many webinars and discussions and panels about musculoskeletal or what have you. But then there are those parts of our of physiotherapy that are lesser known, and I think intermittent claudication is one of them. And I think what Thomas presented and what they're doing in the Netherlands is amazing, and it's making a real impact both on people's health and on the economic side of it, which is also nowadays very important. So I think the fact that you and your association decided to adopt the guidelines, the international guidelines, it's great. There is a question for Thomas. Michal, I'm sorry, I know the answer. It's a short no, but Thomas, someone is asking, it says quite a presentation. My question is, were there other attributes of fitness like lactate threshold or pivotal determinants in prescribing rehabilitation regime for patients with PAD?
This could be an interesting field of study, although I'm not sure whether lactate levels will be elevated in a group that gets a lot of pain while exercising. So that might be challenging. So prescribing exercise here, you need to just think about the way that we prescribe exercise as physical therapists. And we know that doing more exercise and recovering from exercise is important. But you also need to think, can I incorporate this in the lives of the patients? So I think Manos already told us a couple of times that compliance with exercise is very important. I think compliance with the exercise program is actually more important than the exact dosing if a person isn't gonna follow that specific dosing. So
it's sorry, Thomas, it's the Nike slogan, right? Just do it.
Yeah, yeah. Just do it and keep doing it. Keep doing it is I think here the biggest challenge. One of the other questions that I saw is, are there examples of different walking exercises? To be honest, I think many therapists aren't creative enough in how they do these types of exercise. So they make it extremely boring, put people on the treadmill and stand next to it and talk about well, the weather and cows. That's what we do in the Netherlands. I think we could definitely try to innovate in that field. But for some reason, we've made these walking and treadmill exercises extremely boring. So yeah, if the person asking this question has some good ideas, I'm all ears.
Thanks. So we'll go for the last question because we've already run out of time. It's from our friend Marie-Paul. Hi, Marie-Paul, how are you? And it's probably best for Manos. How do you differentiate the neurogenic from the vascular claudication?
Yes. There probably are a lot of things you need to consider. So in neurogenic claudication, there will be a history of low back pain. In vascular claudication, there will be a history of cardiovascular problems. Having said that, most of the patients with neurogenic claudication suffer from spinal stenosis, and they are typically very old patients. So they will have similar risk factors with the vascular patients. So that's why you need to differentiate between neurogenic and cardiovascular claudication, because they will smoke, they will be obese, they will have high blood sugar, they will have perhaps they might take some medication for blood lipids or for high blood pressure. So that's why you need to use a good clinical reasoning and differentiate. The important thing is neurogenic claudication has a postural component. So it is relieved with spinal flexion. So you can use the treadmill, incremental treadmill test and the bicycle test. So if you have the patient on the bicycle and you have the patient upright with the spine upright, the maximum distance or the maximum time, whatever you want to measure, it will be less compared to having the same intensity with the spine flexed. Similar thing you can do with the treadmill, and you can notice that the distance, the maximum walking distance or the maximum walking time will increase. This will not happen in the vascular claudication. It doesn't have a postural component. The other thing is the peripheral pulses also. They might be weak or absent pulse in the dorsal artery of the foot, for example. There might be some skin changes in the vascular claudication that you are less likely to get in the neurogenic claudication unless they have also a vascular problem. So for example, there might be color changes, there might be trophic changes in the skin or the nails. So these are some things that you can use to differentiate between neurogenic and vascular claudication.
Thanks. So we are almost at the end. So first, before we end, before I go over to Esther-Mary, I would like to ask Leah, who was managing the chat and the questions, Thomas, for a very interesting and enlightening presentation. It is very impressive. For Manos, Robert, and Michal, for your contribution and for the discussion. All the participants, I really think, I mean, I'm proud that we are doing what we set out to do, which is bring professional knowledge, which is not as well known, to as many places that we can.
Welcome, everyone. I'm really delighted to see that we have many colleagues from around the world, and those of you who are still with us, if you please even just put your country in that you're coming from, it will be great. I'm thankful to World Physio, who also advertised this for us. But I think that as Nirit and Tomas have said, it's a relatively new area in physiotherapy. It's one that we wanted to bring to you through the professional practice working group, and I thank Nirit and Liz for Leah for that. But I think that we have a great opportunity here, because if you look at the European Society for Vascular Surgery, their guidelines of last year, combined with the American Heart Association in 2017 and the American College of Cardiology in 2022, they've all talked about a concerted effort towards conservative management alone of intermittent claudication. So this really is a very strong piece for us. And if I may just refer in closing to Tomas's words as well, as a person who is very involved in person-centered care and shared decision-making, I agree that it's got to be that balance. We are still the people with the expertise, but really what you're doing is involving the patient in the decision making, and it's, you know, it has consent on one side, as Manos said, giving them all of the information and facilitating them to make those decisions, but also guiding them. And this is why motivational interviewing is so important and needs to be a part of our work, regardless of whether we're working in intermittent claudication or we're working in MSK or what area of physiotherapy that we're working in. So now we have the guidelines through the KNGF, they have the data collection, we have our expertise here in Neurogenic as well as in Vascular. So thank you. It's been very stimulating to listen to all of you, Robert, Manos, Michal and Thomas. So thank you very much, and thank you to all of our attendees. Please put your country, as I asked, in the box, and please keep a lookout for our next webinar. Thank you very much.